All right, so we've reached the half-hour mark, so let's get started. Welcome everyone to this week's installment of AMSSM's National Fellows Online Lecture Series. My name is Haruki Ishii, one of the sports medicine physiatrists at NYU. I'll be your moderator for tonight. This lecture series is sponsored by the AMSSM Fellows Online Education Subcommittee, co-sponsored by the Education Committee and the Fellowship Committee. And tonight we'll be discussing about the MRI series foot and ankle. Before we get into our topic for tonight, I want to remind everyone of next week's lecture on acute muscle injuries, which will be given by Dr. Ryan Cruz and will be moderated by Dr. Robert Bowers. So the goal of this National Fellow Online Lecture Series is to serve as an adjunct to your individual fellowship program education and then to provide sports medicine fellows with direct access to learning from experienced AMSSM members and guest speakers in a variety of formats. Also, this is meant to assist in CAQ exam preparation. Some housekeeping items. So please mute your device's microphone and then turn off your video. You can submit questions at any time through the chat function and feel free to include your name and program if you wish. At the end of the talk, I, as a moderator, will ask the questions during the Q&A based on the questions submitted. Please also complete the evaluation at the end of the lecture. One of our new efforts is to facilitate more input from our audience, and there are a couple ways to do this. So first, a web link can be found by going to amssm.org, click the Education tab, and then select Fellow Online Lecture Series. The link is near the top of the page as seen in this screenshot. The second is by scanning this QR code. It should take you directly to the form to fill out. When filling out the form, we ask that you please keep in mind that the primary goal of this series is to assist in CAQ preparation for the fellows. And now I'd like to introduce you to our expert speaker tonight, Dr. William Walter. So Dr. Walter is an associate professor of radiology in the musculoskeletal division of the NYU Grossman School of Medicine, Department of Radiology, where he recently served as the program director for the Musculoskeletal Radiology Fellowship from 2021 to 2024. Dr. Walter has a strong interest in multidisciplinary medical education and has been a recipient of many teaching awards for medical student, resident, and fellow level education. His clinical and research interests include outcomes of ultrasound-guided musculoskeletal interventions and real-time dynamic MRI. Now, without further ado, please welcome Dr. Walter.
We'll go ahead and get started here. So it's kind of a beefy topic. Please, as Dr. Ishii said, feel free to ask questions in the chat as they come up. I will be covering this agenda here. So we'll be looking first at the ankle and hindfoot, ligaments, tendons, and then osseous and articular findings. Then we'll look at the painful forefoot with some review questions at the end. So we'll start with the ligaments in the hindfoot, and I'm basically grouping the ankle and hindfoot here and showing you these two fields of view, partly because most institutions, certainly at NYU, we do this where we have ankle MRI and forefoot MRI as separate imaging exams. And that's because a lot of the structures and many of that you'll see tonight are relatively small and difficult to assess on a large field of view image. So we usually do not image the entire foot in one field of view. This can really hinder our signal to noise ratio and our spatial resolution for these small structures. So these are the relevant fields of view at many institutions, I'll say, where we image the hindfoot all the way up through the Liz Frank joint in one set of images, and then the forefoot on its own. So we'll look at the ligaments, just reviewing the anatomy. The normal syndesmotic ligaments occur at the distal tibiofibular syndesmosis. You're probably mostly aware of these. And these are the anterior inferior tib-fib ligament, or AITFL. the posterior inferior tib-fib ligament, and the interosseous membrane and ligament. And the interosseous membrane is a sheet-like structure that runs the length of the tibial and fibular diaphyses, and it has a thickening at its distal terminus known as the interosseous ligament. And that's really what we see on the superior most slices of most ankle MRIs. These ligaments, as shown in this little diagram here, are best seen in the axial plane, and we'll see examples of them on actual MR images in a moment, but these run at a slightly oblique plane, but mostly in the axial plane, so they're best visualized in that way, as shown here. The lateral ligaments just slightly lower than the syndesmosis. Primarily, we're looking at these three ligaments here, the ATFL, that's the anterior talofibular ligament, PTFL, or the posterior talofibular ligament, and the CFL, the calcaneofibular ligament. That's this one here, running from the tip of the fibula deep to the peroneal tendons and attaching to the lateral wall of the calcaneus here. These again are also seen best in the axial plane. They're at just slightly oblique axial um, orientations here, but they're best seen in the axial MRI series. So here we're looking at two axial images, the T2 fat suppressed and proton density images, and I won't get into MRI physics tonight, I promise. But this first image, this T2 fat suppressed image, is a fluid sensitive sequence where basically anything that's bright has some fluid component, whether it's blood, pus, edema, hemorrhage, things like that will show up as bright on this sequence. So it's very useful because fractures, stress injuries, tears, tumors will all appear bright on this particular sequence. So we're looking here at the interosseous membrane or ligament here. This is the thickened distal terminus of the membrane running in the midline between the tibia and fibula here, just at the level of the distal syndesmosis above the ankle joint, as you can see here on the scout image. Here are the anterior and posterior inferior tib-fib ligaments. So these are the other syndesmotic ligaments. And as you're noticing on these images, the ligaments, they are relatively thin. They appear as dark bands of tissue, continuous bands of tissue, right? We're not seeing any discontinuities or tears. And they are relatively thin. When they get torn, their imaging appearance will change, and we'll see that in a moment. So here, even lower down, these are the lateral ankle ligaments, the low ligaments. These are the ATFL, the anterior talofibular ligament here, spanning from the anterior distal fibular tip to the lateral aspect of the talar body. This is the posterior talofibular ligament here. It has multiple bands of tissue, so it has this kind of striated appearance, and that's normal. The calcaneofibular ligament is the most difficult to visualize. We use some landmarks to help us find it, and that's namely that it passes deep to the peroneal tendons near the lateral calcaneus here. So these white arrows are pointing to the peroneus longus and brevis tendons as they course distal to the fibular tip, and the calcaneofibular ligament will attach at the lateral wall of the calcaneus just deep to those tendons. Sometimes it can be hard to visualize in the axial plane, and we may need the coronal plane to help us out. And here you'll see this linear structure here, again, low signal, linear, continuous structure extending from the fibular tip to the lateral wall of the calcaneus, deep to the peroneal tendons. Okay, when we have an ankle inversion injury, you're all well aware of the fact that that's the most common injury mechanism for most ankle sprain injuries. You put these lateral ligaments and sometimes the syndesmotic ligaments under distractive forces with inversion of the foot. And so they tear. They typically tear in a predictable sequence from anterior to posterior. So the ATFL followed by the CFL are by far the most common ligaments that we see torn on imaging. and the PTFL is usually last to tear and is relatively uncommon to tear. So the ATFL and CFL in this case are torn, and I'll show you that here. So the yellow arrows are pointing to the abnormal appearance of a torn ATFL. And I'll show you the normal comparison in a moment, but remember this should be a dark, linear, intact structure, and instead we see that it is expanded and replaced by a lot of edema and fluid around where we expect that ligament to be, and this is what a ligament tear looks like. Here, coursing deep to the peroneal tendons at the lateral calcaneus is what we would expect to be the intact calcaneofibular ligament, and it is torn. We see just high signal, abnormal, indistinct thickening of what should be a nice dark black structure here. This is a ligament tear as well. The PTFL, as expected, is intact. These all tend to look very similar. So here's another acute ATFL tear. There is no linear low signal or hypo-intense structure at this site, expanding between the talus and the fibula. Here's a normal for comparison. You see it's outlined by a little bit of fluid in this normal case, but this is again an acute tear. These all look the same, another acute ATFL tear. On the proton density sequence here, the main feature is that it's indistinct and kind of has fuzzy borders. We don't really see normal fibers here because that ligament has torn. Another acute ATFL tear, lots of edema around the indistinct ligament. So as these ligaments begin to heal, especially in the setting of a partial tear, the ligament will begin to granulate in and basically get scarring and remodeling of the ligament. And so it will look thick. And this is an example of a healing ligament here in the setting of a subacute sprain injury. And it's abnormally thick and it's still a little bit hyperintense, but it's not completely replaced by edema and fluid, and we can see the edges of it as it begins to heal. You can diagnose this on ultrasound as well. This isn't an ultrasound talk, but this ligament is abnormally dark, thick, and has some abnormal vascularity within it as it's healing. When there's a mature fibroblastic response with complete scar remodeling or healing in of that torn tendon, the ligament turns dark. And so here we see a markedly thickened, low signal or dark ATFL that is scar remodeled. So this is completely replaced by scar at this point. It's very abnormally thick in the setting of an old healed tear. And this is the same ligament on ultrasound here from the fibular tip to the talus. When we have an old ATFL tear, if it's an old full thickness tear, oftentimes the torn tendon fibers, they're so disorganized, disrupted, that they do not scar and granulate in, but in fact, they just get resorbed. So sometimes we'll see if someone has had an old injury, the ligament fibers are completely resorbed, as it was the case here. There are no intact ligament fibers, none to be found on ultrasound. And this is just an example of a little anterior drawer test here with an unstable tibiofibular, talofibular relationship here with lack of an ATFL. All right, here's an important type of injury. This is a young patient who had a sports injury. And we see a couple of axial images through the ankle and then a coronal image over here. And I'll walk you through them. But you'll notice this is the fibula. So this is the lateral side of the ankle here and here. And of course, this is the fibula coming down. So this is the lateral ankle. And this is a high ankle sprain or a syndesmotic ligamentous injury of the ankle. This arrow is pointing to the expected location of an intact anterior inferior tibiofibular ligament, or the anterior syndesmotic ligament. and it is disrupted. This is the torn and balled up tendon ligament attaching to the tibia here, and it is retracted from its fibular attachment. The PTFL is back here. It looks partially torn, just very heterogeneous and disorganized. That's the PITFL. And then the interosseous ligament here, completely disrupted. You're seeing a few fragments of the ligament or membrane here, and there's just edema all throughout this area around the syndesmosis. There's fluid filling the superior syndesmotic recess here. There's a normal recess of the tibio-talar joint in this location, but it only extends approximately 1 centimeter above the talar dome. And so if you see fluid extending up into the syndesmosis beyond that centimeter height, this indicates that there's disruption of the ligaments that normally delimit that part of the joint recess. Okay, so that's just looking at a few examples of normal and abnormal ligaments around the ankle. I fully recognize I'm skipping over the deltoid ligament complex, spring ligament complex. We can still look at those on MRI very well. They're slightly less commonly involved clinically, which is part of the reason I left them out, and also just for purposes of time. But recognize that anatomy, it's a little more complicated, but we can still see those ligaments and assess them on all normal MRI ankle protocols. Okay, so we'll move on to the tendons now. I trust you know your tendon anatomy at the ankle, but I will review it a little bit just as a refresher here. This is a lateral view of the ankle showing the peroneal tendons, and that's how I'll be referring to them. Some centers refer to these as the fibularis tendons, but we call them as peroneus longus and brevis. We'll look at those. Recall that peroneus brevis attaches to the base of the fifth, and peroneus longus courses under the midfoot through that tunnel underneath the cuboid bone as it passes plantar to the foot. From the medial projection here, we see the tarsal tunnel behind the medial malleolus, and that has the posterior tibial tendon labeled here, inserting at the medial navicular. It has your flexor digitorum longus and flexor hallucis longus, or FHL, tendons in that order as they pass behind the medial mal. The FHL has to make its way to the great toe. The FDL has to make its way to the lesser toes. And so they must cross at this point in the plantar midfoot known as the knot of Henry. Okay, these are axial slices of the ankle, very familiar to us now. Here's the anterior or extensor compartment. We have the from medial to lateral anterior tibialis, extensor hallucis longus, and extensor digitorum longus tendons here. Just deep to them is the dorsalis pedis neurovascular bundle. At the so-called tarsal tunnel here behind the medial malleolus at the posterior medial ankle, you have posterior tibial tendon, flexor digitorum longus, and flexor hallucis longus with a rather large muscle belly. That's normal for these structures. The muscle belly of FHL is low-lying, and so you'll see this muscle along with its tendon here. Interposed between FDL and FHL is the posterior tibial neurovascular bundle here. We've got the Achilles and plantaris tendons posteriorly, and then laterally tucked behind the distal fibula here is the peroneus longus and brevis tendons. Peroneus longus will be on its own as a tendon. Peroneus brevis has a low-lying muscle belly. The tendon is shorter, and that's why part of the reason it's called peroneus brevis. And so this is a normal configuration. Peroneus brevis will pass closer to the fibula in general, so it will be deep to the peroneus longus as we approach the fibular tip, and the brevis is next to bone, is how I remember that. Okay, so what can go wrong with the tendons? The most common thing is just wear and tear, degeneration of the tendon. We call this tendinopathy, tendinosis, basically synonymous with tendinitis, which we consider to be more of a clinical term. But a tendinopathic tendon will be thick. So here you're seeing a really swollen looking posterior tibial tendon. It's dwarfing the FDL right next to it. It will be abnormally bright on T2 weighted images. So it has this internal signal hyperintensity. That's edema and fluid clefting within the tendon. That's abnormal, indicating that it's tendinopathic. You may have small tendon tears in the setting of tendinopathy. You may have tenosynovitis surrounding the tendon or peritendinous edema, reactive edema, or inflammation around the tendon. But in general, we look for swelling of the tendon and high intrinsic signal within the tendon to diagnose tendinopathy. This is an example on ultrasound showing a tendinotic tendon. It should be a bright oval, and instead we see it's swollen, more circular, and it has this intrinsic low signal within it, hypoechogenicity of a tendinotic tendon. Here's someone with a partial tear of the posterior tibial tendon. The tendon itself is labeled by the arrow. It's kind of this whole thing here. You notice there are multiple fragments to it with a linear cleft of fluid running through the substance of the tendon, and that is the tear. There's fluid around the tendon, that's tenosynovitis within the tendon sheath. And here again, this partial tear. I know it's partial because the torn tendon ends are not separated by a gap. There's no tendon retraction. And these fibers, at least some of them, are still in continuity to the insertion upon the navicular here medially. So here's someone with lateral ankle pain. And the abnormality is regarding the peroneal tendons here. And this is labeling the normal peroneus longus tendon, which is herniating into the abnormally configured peroneus brevis tendon. Looks kind of like a C shape or a boomerang. And this configuration is known in the literature to be a sign of a split tear of the peroneus brevis tendon. That's a very common type of tear that we see at the lateral ankle. Here it is in longitudinal here. The peroneus longus tendon is kind of cradled within this splitting post peroneus brevis tendon here. So these split tears, there's some controversy around them because they're so common, especially in aging populations. It's hard to know which one is actually causing symptoms and which is just an innocent bystander. But when there is suspicion that this is a cause of pain, surgery is sometimes performed, and these are just some intraoperative images showing you the split tear of the tendon. And the reason why there's some controversy around how important these are is because you can see even from these images, it does not it doesn't jeopardize the end-to-end integrity of the tendon. So there's a split tear within the fibers, but there's no torn or retracted tendon stump. It still makes it from point A to point B. And so there's still function of the peroneus brevis tendon in this setting, but this is thought to be a cause of pain in some situations. Here's an example of an uncommon tear, but certainly possible, a complete rupture of the peroneus brevis tendon here. So we'll look at this. This is the normal peroneus longus tendon, this black ovoid structure as I move distal from the fibula down to the fibular tip and below the fibular tip. Around it here is the torn split tear of the peroneus brevis tendon. It's almost fully encompassing the intact peroneus longus. It kind of swirls around posteriorly here. Here it is very bright and swollen, lots of tendinosis going on, and then suddenly it disappears. So on the sagittal view, you really get the full story. This is peroneus longus intact, and peroneus brevis here with a tear and a proximally retracted stump, and it just suddenly falls away. This is a retracted, complete rupture of that tendon. All right, another really important and common etiology for ankle pain is Achilles tendinopathy. Here we're seeing the Achilles tendon abnormally rounded. It's almost circular here in cross section, and it's usually flat or slightly ovoid. It has abnormal signal hyperintensity on T2 weighted images within the substance of the tendon. So it's really meeting our criteria for tendinopathy. Has this kind of fusiform thickening pot belly appearance of the tendon, and that is abnormal. Here's another example. These all look very similar. Swelling and signal hyperintensity in the substance of the tendon here, really proximal to its insertion. It's in the distal tendon, but usually a few centimeters proximal to the Achilles insertion. That's the most common site to develop this form of tendinopathy. When a tendon is degenerated, it can subsequently tear. And so this is an example of someone who has a full thickness tear through a previously tendinotic tendon. You can see that it's full thickness because the tendon is no longer linear or in continuity. So we see there's a fluid-filled gap. That's this bright stuff is all fluid on this T2 weighted sequence. And the tendon ends are barely touching here. There's a little gap in between, but they appear to be pulled back from each other, and there's this laxity, which is kind of the telltale sign that there is not mechanical continuity between those fibers. So this is an example on ultrasound, just showing the Achilles tendon. These are the torn tendon ends pulled back from each other. There's some hemorrhage and fatty tissue in the intervening gap here. These tears are, as I said, that location just proximal to the calcaneal insertion is most common. There's usually underlying tendinopathy preceding the tear, and this is considered a critical zone of the Achilles tendon due to a watershed vascular supply. Risk factors include diabetes, fluoroquinolone, deposition diseases like gout, and there's a bunch of other risk factors as well. Very common etiology. So here's an example of a partial Achilles tendon tear. It looks kind of similar in that you have this laxity of fibers here. It's a little bit more filled in. I don't see any clear fluid cleft or anything like that. And as we scroll through the axial plane, we'll watch this tendon kind of spiral through that area of the tear. So there's definitely some high-grade partial tearing going on, but some of these fibers remain intact across the tear gap. So this was a high-grade partial tear. I'll say, I don't think I have an example here, but this is also very well evaluated by ultrasound. And sometimes having that real-time input, you can move the foot, squeeze the calf, get some extra information about whether or not these tendon ends truly gap apart and how much mechanical integrity is really there. All right, we'll move on now to bony findings at the ankle. So I'll start with these. This is just some normal a few normal variants for you. If you look at a lot of x-rays of the foot and ankle, you know that there are a lot of sesamoid and accessory ossicles that can form all over the foot and ankle. They can be in the hand and wrist too, but they're much more common in the foot and ankle. And I've included a few here to highlight as part of this talk, but there are many more. This is very common, an accessory navicular ossicle. They come in 3 flavors according to the literature. So the smallest one is a type 1. This is also known as an accessory, an os tibiale externum. These are usually just a couple of millimeters, so quite a small bone. I don't know if it projects well over Zoom, but just a very tiny pea-sized bone. This is entirely embedded within the posterior tibial tendon and rarely causes any issues. The type 2 is really the problematic one. This is more in the range of about a centimeter in greatest axial dimension. So it's a more substantial piece of bone. It's big enough to form a little pseudarthrosis along the native medial tuberosity of the navicular. And that pseudarthrosis can degenerate. There's motion, especially with the inserting posterior tibial tendon fibers. It can degenerate, cause hypertrophic osteoarthritis and pain. And that's really the culprit behind os navicularis syndrome. There's a fused type, that's a type 3. This results in a prominent navicular tuberosity. I think it's odd to call this an accessory navicular. It's all one bone, but this can be rather protuberant. It can be symptomatic. It alters biomechanics in the area a little bit. So this can also occasionally cause problems. All right, this is an os peronium. The main issue with this one is that it gets mistaken for something abnormal when it's entirely normal. It's a little ossicle plantar and lateral to the cuboid bone. It's embedded within the peroneus longus tendon just before it sweeps underneath that cuboid tunnel. So this is just something to recognize. It can be all kinds of different sizes. We see it bipartite, multipartite sometimes. It can be present on one side and not the other, and it's rarely a cause for pathology. Here's an os trigonum. This is an ossicle posterior to the talus at the level of the posterior subtalar joint. It's an independent ossicle when it's not fused to the underlying talus. It can be fused to the underlying talus, in which case it's known as a steata process. In either case, the os trigonum or a steata process, it can be a cause for posterior ankle impingement, but this is also a very common ossicle, and it is most often asymptomatic. Posterior ankle impingement is thought to be most common among dancers, classically ballerinas, because the extreme plantar flexion required by their positions will cause this kind of nutcracker effect on the os back here between the posterior tibial plafond and the superior calcaneus. When you get that nutcracker effect, you'll get this inflammation around the os. You see here it's entirely filled in with abnormal bone marrow edema, and there's some fluid and synovitis in the joint recesses around it. This person has imaging findings of posterior ankle impingement. All right, this is a normal phenomenon that you'll see on a good share of the ankle MRIs that you look at. These are cysts that form at the angle of Gissan along the calcaneus. And this is basically this angle along the posterior subtalar joint. It's a very common location to have perforating vessels. And so you'll get cyst formation here, some bone marrow edema and fluid. Your neighborhood radiologist probably will not mention this on their imaging report because it's so common and is of no clinical consequence. All right, so here's an older patient who has chronic lateral foot pain and pes planovalgus alignment. So these are weight-bearing x-rays. I know it's not an x-ray talk, but we always start with x-rays if we have them when we're interpreting our MRs. And you'll notice that this hindfoot is in valgus, and it's quite planus as well. The flat foot is quite severe here. You see the talar axis is basically purely pointing in a plantar direction here. And these findings may or may not be flexible. I'm not giving enough information here for us to tell that. But this person went on to have an MRI because they were having this chronic pain. And we see these findings of bony impingement here. So I'll walk through these. This is a sagittal T1 weighted image, and we're seeing this bone marrow edema both along the angle of Gissan of the calcaneus as well as the talus here along the edges of the subtalar joint. And this is the sinus tarsi here. On a coronal view, we see this elongated, broadened, abnormal contact between the lateral talus and the lateral calcaneus over here. Sustentaculum tali is over here medially. So this is an abnormal configuration. There's fluid between the bones. You can see there's edema, cysts, and there's just abnormal degeneration occurring at this abnormal bony contact. It's not a true joint because these bones are not meant to touch, But because of the collapse of the medial arch, these are brought into contact with weight bearing and they get degenerated over time. The fibula here, shown on this coronal image, is actually touching down on the lateral wall of the calcaneus, a very abnormal configuration if you think about it. These are the peroneal tendons, just distal to the fibular tip here. These can get impinged between the bones. And you'll see these cystic changes. These are degenerative changes related to abnormal bony impingement in this patient with extra-articular lateral hindfoot impingement. So they've got this abnormal subtalar and calcaneofibular bony contact. And this is thought of as kind of a series of, of progression of this disease. So common associations, you probably know this better than me, with flat foot, posterior tibial tendon dysfunction. Tarsal coalitions can also be a cause, so abnormal fusions between the tarsal bones, bony bars, that kind of thing. And then spring ligament insufficiency is also a known important cause. All right, so here we've got a 28-year-old who had ankle pain. They have instability, and couple of X-ray images. We'll zoom in on this one. You'll notice that there's lateral ankle swelling, and there's a piece of bone here adjacent to the lateral talar dome. There does appear to be a little lucent notch out of that talar dome, and this was actually a displaced piece of bone. So this person got an MRI to evaluate for an osteochondral injury. Here at the lateral talar dome, MRI is confirming that there is a notch of bone missing from the talar dome articular surface. This is the little piece of bone that we were seeing on the X-ray. And you'll notice as you trace along the articular surfaces, there's intact cartilage. That's the gray stripe here. The black stripe is the bone of the subchondral bone plate. And then the rest is the internal bone marrow of the cancellous bone. So here is the crater of the osteochondral defect. This is the piece of bone. And you'll notice that it looks like it's flipped over within the crater. The cartilage is here, the subchondral bone plate is here, and the rest of the bone is here. So this is actually a displaced, unstable osteochondral fragment or injury within this osteochondral defect. And this actually has a name. It's called the lift lesion, lateral inverted osteochondral fracture of the talus. They're not common, but I have seen a few of these in my practice over the years. And it's just an example, kind of a nice one of an unstable osteochondral injury. These come with, multiple grading systems. We try not to use grading systems just to avoid any confusion if there's disagreement on what each individual grade means. But basically, most grading systems progress from a bone bruise to a stable fragment to a frankly unstable fragment. And there are findings of instability on MR that you can read about. They include undercutting of the fragment with fluid signal and cyst formation along the edges of the piece of bone, which is thought to reflect some micromotion and instability going on. This is a grade 1 injury of the tibial plafond. So remember, these are not just along the talar dome. They can happen along any articular surface. So that was a stable lesion here. And then this is just a pitfall to be aware of, known as the notch of Hardy. At the anteromedial tibial plafond, there is this defect in the bone, a small notch. This is totally normal, an anatomic site that arthroscopists are actually well aware of because this forms a widening in the joint that serves as kind of a nice port for arthroscopy. And this is not to be mistaken for an osteochondral injury. Okay, so we'll move on to the painful forefoot. I've got a couple of case scenarios here before we go into the review questions. So I think we're doing well on time. So this first case scenario, painful forefoot, rule out plantar plate tear, very common situation. And you notice on physical exam that the patient has a tibial drift of their second toe. It's causing this kind of splayed appearance between the second and third toes. The X-ray bears that out as well. You can see this second toe is kind of tilted medially. This diagram is just showing that this pathology is commonly associated with a particular parabolic arch of the metatarsal heads, where the longer second metatarsal predisposes patients to second MTP plantar plate injuries, just from chronic weight bearing on this sort of predestined biomechanics. So let's look a little bit at the plantar plate anatomy, and then I'll show you some imaging findings, normal and abnormal. So the plantar plate is this dark structure here, and there's a lot to look at in this diagram. I am not here to teach you in-depth anatomy in this area, partly because it's rarely clinically relevant, and we also just can't see each of these individual structures very well on any imaging modality right now. So it wouldn't really serve much purpose. But the plantar plate is this fibrocartilaginous structure. It's basically a thickening of the plantar aspect of the MTP joint capsule. And it attaches with a lot of things shown on this diagram. So it attaches to the plantar fascia. It attaches to the collateral ligaments along both the medial and lateral side of the joint, which in turn attach up to the extensor hood. The flexor tendon is independent of the plantar plate, but it passes right over the top of it, or right superficial to it, I should say. And it glides along the plantar plate there. The plantar plate is attached to the flexor tendon sheath, as you can see in this short axis image. So it is very closely related to the flexor tendons there. So this is the normal MR appearance of the plantar plate, and I'm showing you the white arrows are pointing to the normal plantar plate tissue. It's this dark, intact, curvilinear structure along the plantar metatarsal head. The yellow arrow is showing you a normal cleft that occurs in the mid-sagittal plane right as it attaches to the proximal phalanx. This cleft should be very thin, less than 2.5 millimeters in length. And it really, you shouldn't see it as you scroll from medial to lateral across the plantar plate. On short axis, the plantar plate forms this nice U-shaped structure. Again, it's linear, it's dark in signal, and very closely associated with this little blob of tissue here. This is the flexor tendon in short axis. Over on this image, here's the flexor tendon coursing just plantar to the plantar plate. So this is a plantar plate tear. These arrows are pointing to the torn tissue. This should remind you a little bit of the torn ligamentous tissue at the ankle. It's edematous, it's ill-defined, and we should be seeing, like on this image, we should see that nice U-shaped dark tissue. You see it pretty well over here, and then here at the lateral aspect of the plantar plate, there's a tear. There's also a bunch of edema around the MTP joint. This patient has imaging findings of capsulitis, basically. They have some fluid around the flexor tendons. That kind of makes sense that there would be bleeding into the tendon sheath if you tear the plantar plate because it's so close in proximity to those flexor tendons. On the sagittal image, that 2.5 millimeter cleft is markedly widened. So the plantar plate tissue has torn and pulled back from the proximal base of the proximal phalanx. And as we scroll out laterally, we'll see that there's just no continuous dark tissue right here attaching to the base of the proximal phalanx. So that's a full thickness tear of the lateral part of the second MTP plantar plate. And this is a very common site of tear. Most commonly second MTP joint, most commonly that distal lateral portion of the plantar plate. And we can see this on ultrasound as well, labeled here. It can be helpful sometimes to put dynamic stress on ultrasound and kind of open up that tear gap to better characterize it, but MR is perfectly adequate to evaluate for a plantar plate tear. All right, so clinically, You probably know these signs better than me, but you can get this crossover deformity as the toe begins to have a hammer toe deformity, this tibial drift here. And this is a normal paper pull test where the patient is demonstrating adequate purchase of the toe on the ground to allow them to tear that paper. All right, the last topic we'll cover here is neuroma, interdigital neuroma. So this is a patient with suspected Morton's neuroma. They have a positive Mulder sign, and yeah, we'll look at some imaging findings of Morton's neuroma. So the digital nerve here, um, it passes along the plantar interspace between the metatarsal heads. There's also a bursa that lives slightly more dorsal to the nerve, and we'll look at that anatomy in a little more detail in our case. But this diagram is also showing this. This is the transverse intermetatarsal ligament here, which delimits the bursa between the metatarsal heads from the plantar soft tissues, which contain that proper digital neurovascular bundle. And so it is said that a neuroma should extend more plantar and a bursitis will be more directly between the metatarsal heads. So here's a Morton's neuroma on MRI. It usually forms this pooching ovoid mass extending in a plantar direction. It's slightly T2 hyperintense here. It's not fluid bright. It's somewhere in between, kind of a brighter gray color here. And it looks mass-like. And so that's a very classic Morton's neuroma. On ultrasound, we can see these. We usually apply some pressure with the probe to make sure that they don't collapse, in which case it might just be a fluid-filled cyst or bursitis. But in this case, it was a solid lesion, and this is a very classic Morton's neuroma. Here is intrametatarsal bursitis, just for comparison's sake. This is fluid bright. It's directly between the metatarsal heads, and it's a little bit less mass-like. It's usually just more thin. If it gets swollen or engorged enough, it may pouch out, usually in a dorsal direction rather than plantar, because of that transverse intermetatarsal ligament. And you can see it in multiple web spaces in this patient over here. You'll notice that differentiating these, it's mainly morphological. It is not anything to do with contrast enhancement, although we can certainly find papers in literature that tout the ability of contrast enhancement to help us make this distinction. A neuroma will probably enhance solidly, and a bursitis should not. Should have some enhancement around the edges, but not solidly within it because it's a fluid-filled structure. But we do not regularly use gadolinium to help us make that differentiation. We have reliable enough differentiation just on the kind of anatomic and morphologic appearance that it's just not necessary, cost effective, or really the right move for the patient. One little pitfall I threw in here is a differentiation between a neuroma and a pseudoneuroma. So if someone has had a plantar plate tear, as this patient has at the second MTP joint, they can get this granulation and scar reaction similar to the healing ligament at the ankle. And it can form scar tissue in the interdigital web space. So it starts to look a heck of a lot like a neuroma. It's plantar, it's low on T1, it's kind of mass-like, and it's a little higher on T2. Here it is on ultrasound, sort of mass-like. For one thing, though, their underlying plantar plate is not normal. It is definitely torn. And you'll notice when I place this line in the web space, like the middle of the web space, this mass, so-called, is eccentric toward this plantar plate compared to the third. So if we see this finding and we see this eccentricity of the lesion, not a perfectly centered neuroma like this one, we have to be suspicious about this pseudoneuroma, which is just scarring related to a plantar plate tear. Okay, so we'll move on now to our review questions. So I've got three questions here. They're not hard, um, but they're just designed to kind of raise a few issues, which I think are important to be aware of. So question one, which of these typifies the diagnosis of tendinopathy or tendinosis on MRI? And I don't know if we'll be able to get a poll up. All right, we got one. Okay, so we've got majority answering C here, and that is correct. Um, majority answering C. There's bright signal on T2 weighted images within the tendon that usually represents a little bit of mucoid degeneration, edema, or blood within the tendon. All right, here's question two. On MRI, the ankle syndesmotic ligaments and the lateral ankle ligaments, ATFL, PTFL, and CFL, are best evaluated in which imaging plane? Axial, coronal, sagittal, oblique coronal, or each ligament requires a different plane? All right, so majority get A, that's correct. I wouldn't have expected any different. Axial plane is best for imaging the ligaments of the ankle. No plane is perfect for them, I'll say. We do have some three-dimensional imaging techniques that allow us to create planes in real time. That's probably coming down the pike for a lot of imaging centers. But for now, axial plane is best. And finally, which is correct regarding distinguishing neuroma from bursitis on MRI? Does it require IV contrast? Neuroma should be more dorsal. Bursitis will cause bone marrow edema, or neuroma will be more plantar. All right, very good. So correct answer D, neuroma should be more plantar because of that intermetatarsal transverse ligament. Bursitis will be more on the dorsal side. I'll point out again, does not require IV contrast. We really only advocate the use of IV contrast for suspicion of neoplasm like sarcoma or other malignancy, some complex infection cases, with suspicion of abscess. But most other causes for IV contrast are probably not valid. And I recommend if you're considering getting MR with contrast in the musculoskeletal system, unless it's something you do all the time and you're certain, consult the ACR appropriateness criteria online. It's a great resource that allows you to basically fit your particular clinical indication with the correct imaging study. All right, so that's all I've got. Thanks so much for your attention. We'll do some questions now. If people have any, you can throw them in the chat. If you have questions later on down the line, please feel free to reach out by email. This is my NYU email here. Always happy to help out.
Thank you, Dr. Walter, for such a great topic or talk on a dense topic, right? So thank you for the great talk. Let me see. So it looks like there's one question in the chat. So the question is, do you have a strong affinity for T2 versus 3T for foot and ankle? What about open? Some authors in our group want to see open due to dubious resolution and missing tumors. So is there any thought on that question?
Yes. So currently 3 Tesla is the best for sure. We have 3 and 1.5 Teslas. 1.5 Tesla is perfectly adequate. I think most imaging centers probably have a majority of their magnets that are 1.5 Tesla. So the lower Tesla strength is still perfectly adequate. I don't want to undersell it. 3 Tesla is better. It's better for the patient also because usually we can do faster imaging on it, but it's not always available, and that's okay. I think the part where you do lose a lot of signal is in open MRI, and The foot MR is not a terribly claustrophobic exam because it doesn't require that the entire body is within the magnet. And so usually the head can be on the outside. So patients do tolerate this better. But there are some open MRs. There's standing MRIs, which are also relatively open. And those seem like a great idea for foot and ankle because they're weight bearing. And so you can get a little more information about alignment and anatomy that way. But those, so open and these sort of semi-open weight-bearing MRIs are notoriously bad image quality. So yeah, I would say that there's a strong affinity for conventional MRI over open. And I think especially when it's the foot and ankle, even your nervous patients will do pretty well with that exam in a conventional MR because it's not a brain MRI where their head, has to be right inside the coil, for example. So yeah, that's what I would say about that.
Good. Thank you. I know you didn't have time to talk about, but in terms of the Lisfranc injuries,
Yeah.
would you recommend getting an MRI? Is there, any reason that you would get it on the weight-bearing MRI for the Lisfranc injury? I know that for the X-ray, you want to get it on the weight-bearing to see if there's any gapping of the second metatarsals, but is there any point of doing MRI on the weight bearing? Is it better to get a CT for the assessment of Lisfranc injuries? What's your opinion of that?
Yeah. For the alignment, I think weight-bearing X-rays are still the gold standard. Don't mess around with weight-bearing MRI to do that because the alignment is shown so well on X-ray. I think that's still the standard that everyone will use and be familiar with. Um, so weight-bearing X-ray and then MRI. MRI will show the status of the ligament complex, of course. It's also very sensitive for fractures. Some of the little avulsion, chip fractures, and things like that are shown much more exquisitely on CT. So, of course, I'm the radiologist telling you get X-ray, MR, and CT. I think if I had to choose, I would get the weight-bearing X-ray and MRI, and that's good enough. I think you may discover some little cortical avulsions or chip fragments by CT. Um, because of the exquisite bony detail that it shows, but they're unlikely to be clinically relevant beyond the information that you get from the X-ray and the MR, if that makes sense. So yeah, that's what I would say. But for the purposes of test taking in general, if you're grouping or lumping the purposes of imaging studies, MR is really good for soft tissue stuff. So if you want to see the torn ligament, MRI is your only way to do that. CT shows exquisite cortical and bone detail. So if you want to see detail, three-dimensional fractures, get a CT.
Thank you. So I don't see any other questions, and I know we're almost at 9:30. So thank you again, Dr. Walter, for such a great lecture. And then we'll see you guys next week for the acute muscle injuries. Thank you again.
All right, thanks so much.